As always, let's start with a bit of relevant anatomy. Okay, not a complete type of anatomy, but only the relevant thing which is necessary for us to understand. Esophagus is a 25 centimeter long muscular tube which connects the pharynx to the stomach. So it is a connecting tube between the pharynx, okay, and the stomach. Which pharynx is connected? Okay, which pharynx is that? There are three types of pharynx, the three forms of the pharynx. These are nasopharynx, oropharynx, and laryngopharynx. So which one is connected or continuous as esophagus?
Laryngopharynx, sir.
Lymph.
Absolutely, laryngopharynx, because it is the lowermost part of the pharynx. So remember,
Hypopharynx.
exactly, hypo or laryngo, both terms are commonly used. Hypopharynx or laryngopharynx, it is continuous as esophagus, and it is completed in the stomach. The esophagus extends from the lower border of the cricoid cartilage, which is present at the level of sixth cervical vertebra, okay, to the cardiac orifice of the stomach, and it is present at the 11th thoracic vertebra. So from the 6th to the 11th thoracic vertebra, esophagus is extended. Or if you do not want to remember this number of the vertebra, and this is not very important also, remember the upper landmark is the lower border of cricoid cartilage. This cricoid cartilage is one of the important cartilage of the larynx. Now, there are three big cartilage of the larynx, okay, and other smaller cartilage. The three big cartilage which are present on our larynx are thyroid cartilage, cricoid cartilage, and epiglottis. These are three big one, and some other smaller one are also there, like arytenoid cartilage, okay, corniculate cartilage, and cuneiform cartilage. They are a less important one. Now, this esophagus has got three important constrictions or three important narrow area in its vertical course. Now, why we need to know these three constricted or narrowed part? Because when the surgeon or the doctor is doing esophagoscopy or upper GI endoscopy, they need to know this constricted area. Otherwise, they can easily perforate or injure this constricted part. Okay. Now they are, the first constriction is at 15 centimeter from the upper incisor teeth, where the esophagus commences at the cricopharyngeal sphincter, means right at the lower border of cricoid cartilage, okay, or there the laryngopharynx end, and it starts as esophagus. That area is narrow. That is the first constriction. And according to the distance, it is around 15 centimeter from the upper incisor teeth. That's how the surgeon knows, yes, I am reaching that constricted area because of this distance. This is the narrowest part of the esophagus. Now the second constriction or second constricted area is 23 centimeter from the upper incisor teeth, where it is crossed by the aortic arch and the left main bronchi. Now trachea will divide into two main bronchi, okay, right and left. So this left main bronchi and aortic arch, okay, it is crossing this esophagus, and that part is again narrow. It is roughly 23 centimeter from the upper incisor tooth. And the third constricted area is around 40 centimeter from the upper incisor teeth, where it pierces the diaphragm. The lower esophageal sphincter is situated at this level. So there is a small part of the esophagus which is known as intra-abdominal part, very small one, okay, around 1.25 or 1.5 centimeters. So at that area, exactly at the level of the piercing of diaphragm, the lower esophageal sphincter is present. So this is roughly 40 centimeter from the upper incisor teeth. But remember, the length of the esophagus is around 25 centimeter only. Now let's see the anatomical picture of the esophagus. See here. So this is the esophagus here. Okay, this structure is esophagus. You can see here. This is the bifurcation of the trachea. This is known as angle of carina. Angle of carina. This is right bronchus. Okay, this is the left one. So you can clearly see right bronchus is more wider and vertical than the left. See, these are important, anatomical point you need to notice here. Okay. What is this important structure which is shown here? What is this one? Yes.
Arch of aorta, sir.
Exactly. Arch of the
Arch of aorta, sir.
yes, arch of the aorta. Which is this blood vessel? What is the name of this blood vessel? This one.
Brachiocephalic.
Brachiocephalic trunk. Yes, brachiocephalic trunk. Now, brachiocephalic trunk is giving rise to two important blood vessels. What is this and what is this? What is the name of this blood vessel which is going up? This one. Yes. What is this one? Anyone? This is very basic anatomy. You should be knowing this, That's why I'm asking. Which side is this? Right side or left side? That is the thing you need to know first. Which side is this? And which side is this? See here, this is the left side. This is the right side. So this is right common carotid artery, and this is right subclavian artery. Right common carotid artery and right subclavian artery. Okay. Now this is the left. Right is already done. So we have only two more arteries present on the left side. So this is left. Okay. Left common carotid, and this is left subclavian. They directly originate from the arch of the aorta, but on the right side there is a brachiocephalic trunk, and then those two arteries are the branch of that. So this is arch of the aorta. So here is the esophagus. Okay, see this? This is trachea. Actually, esophagus is posterior to the trachea. This is esophagus here. This is diaphragm. This is the dome-shaped structure called diaphragm, and esophagus is piercing the diaphragm. See this at this level, and below that there is a small part of the esophagus which is lying in the abdominal cavity. This is known as abdominal part of the esophagus. Now, one small anatomical point I like to discuss with you. This is very, very important MCQ question from the anatomy. There are three important levels at diaphragm which are pierced by three important structures. Okay, at the level of 8th thoracic vertebra, T8 we say, T8, the inferior vena cava is piercing the diaphragm. This is inferior vena cava. Look at this blue big blood vessel. Okay, at the level of T10, roughly at the level of T10, the esophagus, exactly, esophagus is piercing the diaphragm. You can see here. And at the level of T12, the abdominal aorta, okay, means you can also say like this, thoracic aorta is continuous with abdominal aorta from T12. So T8, T10 and T12, these three landmarks are very important in relation to the diaphragm. So this is the cervical part of the esophagus, which is present in the neck area. Thoracic part is present in the chest, and abdominal part is present in the abdomen. So esophagus has been subdivided into three portions as follow. The cervical portion extends from the cricopharyngeus to the suprasternal notch, which is present in the neck area. That's why it is known as cervical. Thoracic portion extends from the suprasternal notch to the diaphragm. It is present in the thoracic cavity. And abdominal portion is a very small one, extends from the diaphragm to the cardiac portion of the stomach. This is abdominal part of the esophagus. Now, another schematic diagram here. You can clearly see here. See here, this is larynx. This is the area of larynx. This is thyroid cartilage. This is the cricoid cartilage. So esophagus starts at the lower border of cricoid cartilage, right from here. Okay, downwards is the esophagus, and it ends here at the cardiac end of the stomach. This is stomach. This is called cardiac end. So this muscular tube is esophagus. Anterior to the esophagus is trachea. Okay, it is trachea here. Trachea ends, by dividing into two main bronchi. This is arch of the aorta. So three important narrowing area of the esophagus are at the start area, right here at the level of cricoid cartilage, where the left main bronchi and the arch of aorta crosses it, and then when it is crossing the diaphragm. These are the three constricted area of the esophagus. This knowledge is important when you are doing upper GI endoscopy or esophagoscopy. Now, from the clinical point of view, esophagus is divided into three parts: proximal 1/3, middle 1/3, and the distal 1/3. Okay, proximal 1/3 is present in the neck, middle 1/3 is present in the thoracic cavity, and distal 1/3, very small part, is only present in the abdominal cavity. Otherwise, the majority of the part of distal 1/3 is also present in the chest cavity or thoracic cavity. Now, regarding the structure of the esophagus, this is very interesting fact here. See this? Upper 1/3 is made up of skeletal muscle. Lower 1/3 is made up of smooth muscle, and middle 1/3 is a combination of both skeletal as well as smooth muscle. Now, tell me, what is the nerve supply of skeletal and smooth muscle? Yes, what is the nerve supply? What is the difference?
Sympathetic.
Yes, just this is a general question, is right. Smooth muscle is supplied by autonomic nerve. Okay, autonomic nervous system or autonomic nerve, whereas skeletal muscle is supplied by somatic nerve. We call them somatic nerve. So that's the difference. Skeletal muscle is a voluntary one. A smooth muscle is involuntary. We do not have any control over the contraction of smooth muscle. They are on their own. That's why they are supplied by autonomic nervous system. So upper 1/3 is skeletal muscle, lower 1/3 is smooth, middle 1/3 is combination of both. This esophagus contains two sphincters. These are called upper esophageal sphincter and lower esophageal sphincter. Okay, so two, upper and lower. Now, one very important, histological point here is esophagus is lined by stratified squamous epithelium. Stratified squamous epithelium. Never forget it. The whole of the esophagus is lined by that. Sometimes this stratified squamous epithelium is converted into columnar epithelium because of reflux of the acid from the stomach side, and that is known as Barrett esophagus, which is part of today's lecture. So maybe when we move further, one of the small topic is known as Barrett esophagus. We are going to talk about that. Only less than 3 centimeter lies below the diaphragm. In some of the textbook, it is mentioned as around 1.5 centimeter also. Okay, so you just remember very small part is there. Now, one small question before I move further into the disease part. How many layers are there in esophagus? If we take a cross section, how many layers?
Sir, there is mucosa, submucosa, and muscular layer, sir, and sir, there is lack of serosa.
Sir, basically, say like there are 4 main layers, 5. Say like mucosa, submucosa, and the muscularis propria, adventitia, and the serosa.
Exactly, absolutely correct. Both of them are absolutely right. Esophagus is a part of our GI tract. So there are 4 layers. The innermost layer is called mucosa, then submucosa, then muscular layer, or also known as muscularis propria, and the outermost layer is called adventitia if it is not covered by peritoneum, or if it is covered by peritoneum, we call it serosa. So cervical part and the thoracic part, the outermost layer is called adventitia, whereas in case of intra-abdominal part, we can call it serosa. Okay, so these are the very important basic knowledge of esophagus. Now let's move on. Now these are the list of the esophageal diseases and the condition, okay, which may occur in esophagus. Now let's go through them first, and we are not going to talk all of them, otherwise this will be a huge class. We'll choose the important one. Achalasia or Achalasia cardia is one of the important condition. I'm going to talk that in this class. Achalasia, I'm sure a lot of information is already known to you, but still we are going to revise them, or we are going to talk some new things there. Barrett esophagus is another condition we are going to highlight. Boerhaave syndrome is the third one. Okay, this is the rupture of the esophagus. Esophageal atresia and tracheoesophageal fistula, we'll talk them together. Esophageal diverticulum. Okay, now there are two types of esophageal diverticula we have. One diverticulum is occurring in relation to the pharynx. Okay, so we call that pharyngeal diverticula as well. This is also known as pharyngeal diverticula, which occurs the upper part of the esophagus or lower part of the pharynx. And another is very near to the lower part of the esophagus, and that is known as epiphrenic diverticulum. Epiphrenic. Okay, look at the term phrenic. Phrenic means diaphragm. Epiphrenic diverticulum. So these are two main type of diverticulum which may be present in the esophagus. Just the name are important here. And you all know what is diverticulum. Yes, what is diverticulum? Can you answer here?
Sir, outpouching of the
Outpouching.
dead body.
Exactly, outpouching of the wall, you can say that. Outpouching of the wall, especially the mucosa. The mucosa part may outpouch because of the weak layer of the muscle. And it can have a lot of problem. Number one, it can collect food there. So it may act like a solid mass, and it may compress the main tube after it converts itself into a solid mass. So it is one of the cause of dysphagia. Second, it can contain food which is quite older one. For example, the patient may be having food there which he or she ate 2 to 3 days ago. And when they vomit, the food which they eat 2 to 3 days ago would come out. And they are really surprised. I didn't eat this food today. From where it is coming, isn't it? So this type of clinical feature is quite typical of pharyngeal diverticulum. The third one, there is a component of infection there. There is a component of very old food collection there. So patient's breath is very foul smelling. This is known as halitosis. Halitosis is a foul smell breath. Okay, so these are some of the features of pharyngeal diverticulum. Now let's move on. Another important disease is esophageal carcinoma. We are definitely going to talk about this. There are two types of esophageal cancer. One is called squamous cell carcinoma, another is called adenocarcinoma. Hiatus hernia is another important condition in esophageal surgery. Now, hiatus hernia is herniation, okay, which is occurring through the esophageal hiatus. Hiatus means esophageal opening which is present in the diaphragm. From that esophageal opening, okay, the lower esophageal sphincter is going upwards into the thoracic cavity, or a small part of the stomach is herniating upwards. So accordingly, we have two types of hiatus hernia. One is called sliding type of hiatus hernia, where lower esophageal sphincter is present in the thoracic cavity, whereas another type of hiatus hernia is called paraesophageal hernia, where a part of stomach is herniated up. I will take a detailed class about hiatus hernia, don't worry, okay, in the subsequent lectures. Diaphragmatic hernia. Now, you have studied this somewhere, maybe in pediatrics. This is known as congenital diaphragmatic hernia, where stomach or intestines are herniated up from the defect of the diaphragm. Okay, very, very important condition. in pediatrics. Another condition is esophageal reflux disease. Okay, uh, esophageal is reflux disease, or also known as gastroesophageal reflux disease, GERD. We are going to talk about that, where acid is refluxing up towards the esophagus. Esophageal stricture means constricted part of the esophagus. Because of the chronic inflammation in the mucosa, the lumen may become narrow. Perforation is a through and through rupture of the esophageal wall. Esophageal varices is the dilated vein on the wall of the esophagus. And every student know, 100% of the student know by now, this is a feature of portal hypertension, which may be caused by cirrhosis of the liver. Esophagitis, inflammation of the esophagus, and Plummer-Vinson syndrome. Okay, now what is this?
Basically, it's dyspepsia, iron deficiency, anemia.
We've got three features here.
So
Dysphagia, iron deficiency, anemia,
exactly.
and esophageal web.
Excellent. By the enthusiasm of the student, by hearing that, I'm sure every student know this Plummer-Vinson syndrome. Excellent. It has got different type of component. One is called presence of the wave in esophagus, also known as esophageal wave. Okay, it is associated with iron deficiency anemia, and if we do not take care of this in time, it can predispose to squamous cell carcinoma of the esophagus as well, and it is very, very common in female. So this is known as Plummer-Vinson syndrome. Some of the textbook even mention this as a Patterson-Kelly syndrome. Patterson-Kelly syndrome. Okay, but Plummer-Vinson syndrome is more commonly used term. So see there. So if someone asks, especially in the Viva exam or the oral exam, can you tell me some of the disorder or the diseases which occur in esophagus? You can simply remember these few of them and tell the examiner. Now, let's talk about Achalasia cardia. Now, see here. Now, Achalasia or Achalasia cardia. Now, why the term cardia is there? Because it is occurring very near to the cardiac end of the stomach. Okay, so that's why the term Achalasia cardia or Achalasia only. It doesn't matter. Is a neuromuscular failure of relaxation at the lower end of the esophagus with progressive dilation, tortuosity, and incoordination of the peristalsis, and often hypertrophy of the esophagus above. Now, let me explain this in a very easy way for you. Now, this is a neuromuscular failure of relaxation, means there are certain ganglion cells present in the wall of any GI tract. Okay, there are two types of ganglion cell present. One in the submucosa, another in between the muscle. Now, what is the name of that ganglion cells which are present in the submucosa? What are the names?
Mesenteric plexus.
Meissner plexus. Very good. These are known as Meissner plexus. Whereas the ganglion cells present in between the muscles are known as
Myenteric plexus.
Orbic
Orbic plexus.
very good. Myenteric or Orbeck plexus. Excellent. Myenteric or Orbeck plexus. Now, listen properly. In this case of Achalasia, there is no problem regarding the Meissner plexus, but myenteric or Orbeck plexus is having the problem. Okay, usually that is a problem there. Orbeck plexus is having problem. So because of that, that part of the esophagus which is affected, okay, will remain constricted. It is almost like a horse-sprung disease which we have just studied in colon. Same type of condition. So that area remains motionless. It remains like a area of obstruction. So proximal to that area, peristalsis is normal. So there is vigorous amount of peristaltic movement. Okay, but it is a bit of incoordinated there, and that part of the esophagus will get dilated because of the constant contraction. And this disease is all about these features. So if you understand the basic mechanism here, everything below will be very easy. Achalasia may occur at any age, but particularly in the third to fourth decade. So third to fourth decade means 30 to 40 years of age. Males and female are affected equally, and incidence of achalasia cardia is about 1 per 100,000 per year. It's not very common. What is the etiology, or what is the cause? Okay, now see there. Achalasia primarily involves a neurological defect involving the ganglion cells of the Auerbach's myenteric plexus in the lower esophageal sphincter and esophageal body. So the lower part of the esophagus, which is near to the esophageal sphincter, is affected here. So that area is very narrow, but proximal to that area is very wide, okay, and it is dilated. This is the hallmark of achalasia. The damaging agent has been variously hypothesized as a neurotoxic virus, an autoimmune process, and vitamin deficiency. None has been conclusively demonstrated. So you can safely say this is an idiopathic condition. We really do not know why this condition occurs, but in South American countries like in Brazil, okay, Chagas disease is commonly associated with achalasia. So what is the causative agent of Chagas disease?
T. cruzi.
Trypanosoma cruzi.
Exactly. Very nice. Trypanosoma cruzi. Okay, very good. Trypanosoma cruzi, also known as American sleeping sickness. So that is strongly associated with, achalasia, which may be, discussed in next slide. See here. At its most severe, a peristalsis occurs in the affected parts of the esophagus with normal peristalsis above it. Thus, there is a problem in deglutition or swallowing, which is known as dysphagia. So the patient is eating food, but that food accumulates in the esophagus because there is obstruction now. At the same time, that part of the esophagus becomes dilated and atonic later on. The prolonged transit time may be a factor in the increased incidence of malignancy with achalasia, and the incidence is about 5%. So what does that mean? If achalasia is not treated in time because of prolonged obstruction there, the food remains there. And the food, we different type of food, some food are hot, some are spicy type of food, isn't it? They may damage the mucosa there, and that may be a factor for the development of malignancy later on. When we talk about the predisposing factor for esophageal carcinoma, achalasia is one of the factors. This is the reason. Chagas disease is associated with achalasia cardia, which you already know. Now, let's move on. Let's talk about pathology. What are the macroscopic and microscopic appearance of the achalasia? Macroscopic means gross appearance. Okay, esophagus is dilated with thickening of the wall because it is constantly contracting there, especially the proximal part. Okay, not the affected part. Secondary changes like diverticula and mucosal ulceration may occur in the proximal part. Definitely, diverticula are associated with increased pressure in the lumen, and pressure is increasing the lumen all the time there. So don't be surprised if you see certain diverticula from there. Whereas microscopically, there is absence of the ganglion cells in the myenteric plexus. Very, very important MCQ question in the exam. Never forget it. And there are certain secondary changes due to denervation and stasis, like hypertrophy of the esophageal smooth muscle and mucosal inflammation, which can be detected under microscope. So the most important point here is absence of ganglion cells in the myenteric plexus or Auerbach plexus, and grossly, esophagus is hugely dilated proximal to that affected area. Okay. Now, with this description, now let's talk about the clinical feature. It is very easy for you to understand. Now, what is happening here? There is obstruction, okay, at the lower end of the esophagus. So whatever food we drink or eat will be collected there. So it cannot be collected there all the time, isn't it? Because that is a tube, and this tube will get filled. Okay, there will be regurgitation of fluid upward. There will be vomiting. Everything is happening, and sometimes there is aspiration also. Okay, especially when the patient is sleeping, when the patient is lying on the supine position, aspiration chance is very high. There is chance of recurrent infection also. So all these things are developing in the case of achalasia. Now let's pay attention to the slide here. Gradually progressive intermittent dysphagia, okay, is the hallmark feature of achalasia. The dysphagia is associated with esophageal carcinoma sometimes, okay, and we have to compare the dysphagia because of esophageal carcinoma and dysphagia because of achalasia. Now, in esophageal carcinoma, there is a solid mass there, and that mass is growing all the time. So patient complains of relentless type of dysphagia than achalasia, means very severe type. Patient cannot even swallow anything. In the beginning, probably there is a small gap still present, so patient can swallow the liquid form of the food. But later on, when it is completely occluded, patient cannot swallow even the liquid type of food. So this is in esophageal carcinoma. But in achalasia, there is no complete obstruction. Still something is passing. That's why it is known as intermittent type of dysphagia. Regurgitation of fluid is common from the esophageal sac, and it can easily lead to aspiration pneumonia. Aspiration pneumonia is a serious type of condition. Patient may have a history of recurrent respiratory tract infection because of recurrent aspiration. Dysphagia is more marked for solid than liquid type of food, and the patient may advance to a state of debilitation due to chronic malnutrition because they are not able to swallow the food. Okay, they are vomiting or having regurgitation all the time, and on top of that, they are having recurrent respiratory tract infection. Remember, any infection in the body is a high metabolic state. So whatever energy we are having are burned up or used up because of increased metabolism. On top of that, patient is not able to swallow the food. So chronic malnutrition or severe malnutrition will quickly result. Now, what are the investigation you want to do to confirm the diagnosis of achalasia? So we start with barium swallow. Barium swallow is very, very important type of investigation here. Now, barium swallow means, okay, we give barium, okay, in the liquid form. Now, barium is a radio contrast material. So when the patient swallows that barium in the liquid form, okay, during that swallowing process, X-ray is taken. This is known as barium swallow X-ray. So characteristic appearance is seen in case of achalasia when we take the barium swallow X-ray, and that is proximal dilatation of the esophagus and a distal smooth tapering. Means the affected area, remember, where the Auerbach's plexus or mesenteric plexus are absent, that area looks very narrow. So there is a smooth tapering of the barium. And this is known as broad beak appearance. Broad beak appearance, or sometimes even rat tail appearance. Now, let me write this important term for you. Broad beak appearance, okay, or rat tail appearance. Sometimes question may be asked simply by these terms. A broad beak appearance or rat tail appearance is seen in which of the following condition? If the option is achalasia, you safely go for that, okay, because of the affection in barium swallow it happens, or it is appeared like that. I have collected few of the barium swallow X-ray. We can see this a bit later. Now, second important investigation we can do is esophagoscopy. This is endoscopy of the esophagus. Okay, and it can exclude carcinoma if it is occurring there. A chest radiograph may reveal widened mediastinum with possibly a fluid level behind the heart, because this is a case of obstruction. Okay. So fluid level can be seen if the patient has patient was drinking a lot of fluid, and there is absence of the gastric air bubble because nothing is passing distally, right? Though a bit of food may pass, it's a bit of intermittent type of obstruction sometimes, but still the classical air bubble which is seen in the fundic part of the stomach is often absent here. Another study is a manometric study. Manometric means measurement of the pressure. So it reveals a gastroesophageal sphincter that has a high resting tone and only partially relaxes. Means it is contracting all the time. Okay, there is no real peristaltic movement if we do pressure measurement study. That is known as manometric study. Now we're talking about the investigation which was done for the diagnosis of achalasia. Look at this. This is known as barium swallow study. Barium swallow study. This is a radio contrast material called barium, which is swallowed by the patient, and then at the same time we've taken the X-ray. Now look at this, terminal part of the esophagus. This is acutely narrowed part, and the proximal to that area is dilated. This is a typical appearance, which is known as bird beaks deformity or bird beaks appearance in case of achalasia. Now another picture or another X-ray. This is again the barium swallow. There's a classical bird's beak deformity. In some of the textbook, it is also mentioned as a rat tail deformity. Okay, a rat tail appearance. Both are same thing. Now let's move on. Now, what is the treatment of achalasia? What type of management we can go for? Achalasia is incurable condition because those ganglion cells or the Auerbach or mesenteric plexus which are absent cannot be replaced there again. Okay, that's why it is written as incurable. But we can definitely do some type of other treatment which are symptomatic and supportive therapy, or we can go for the surgery of that affected part. Okay, that will kill the problem, but that is a different type of management, isn't it? What they are talking, why it is called incurable, is there is no certain medicine or certain way that that part which is affected start working again permanently. So treatment can be directed at relief of the distal obstruction in this condition, and that is done by certain pharmacological treatment like intrasphincteric injection of botulinum toxin. It is one of the type of medical therapy. You inject botulinum toxin there. Now, what this botulinum toxin is doing, you all know. This botulinum toxin, okay, will not allow the release of acetylcholine, so that without acetylcholine, okay, that area cannot contract properly. So it will again start developing the peristaltic movement. That is the whole idea. Another way is a pneumatic dilatation or surgical myotomy. Okay, these are some other way. They are not a pharmacological, but they are considered a surgical way of management. Endoscopic hydrostatic or pneumatic dilation, which we just discussed, is other way. Pneumatic means it's a balloon, which has air inside, and that is suddenly pull through that constricted area, so it will make that area a bit wider, and it may help the patient. Let's move on. Now, there are certain surgical management. One of that is Heller suppression. Now, see this important MCQ question which may be asked in the exam. Heller suppression, also known as cardiomyotomy. In this operation, the surgeon cut distal 3 to 4 centimeter of esophageal muscle longitudinally. And after doing this, the obstruction is relieved. The operation has a success rate of about 90% in those who do not respond to pneumatic or hydrostatic dilatation. Both of the latter two treatments may produce subsequent reflux esophagitis. Why there is reflux esophagitis? Can you explain why this occurs after this type of surgery or pneumatic dilatation? Why?
So there is no proper control of the
Because of
lower
that,
esophagus. So there is back reflex of the content into the esophagus and lead to the esophagitis.
Exactly, absolutely correct. The lower esophageal sphincter is gone now. It is damaged by this surgery. So when lower esophageal sphincter or that anti-reflux mechanism is damaged, then acid and pepsin, which are present in the stomach, can easily reflux upward, okay, resulting in reflux esophagitis. Now, these are some of the non-complication of achalasia. One is aspiration pneumonia. Every student can understand that easily because food and water or fluid is not going distally. They are collecting there, and there's a high chance of aspiration into the airway, resulting in recurrent pneumonia. Hemorrhage, okay, because of the inflammation which is going on there, because of the mucosal damage, hemorrhage can occur, and even in around 5% of the time, esophageal cancer can develop. Okay, this is usually the squamous cell carcinoma of the esophagus, and the reason given behind this is prolonged contact time of the food in relation to the esophageal mucosa, because it is not going distally. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.